I have the honor of introducing my good friend Shelby Cuddy, who's the Director of Pediatric and Congenital Cardiology at the Johns Hopkins Blalock, Taussig, Thomas Heart Center. I want to be sure I get all of that together. And he's also the chair of Cardiovascular Analytic Intelligence Initiative at Hopkins. He is an expert in cardiovascular imaging with over 260 peer-reviewed publications, and he focuses on the evaluation of myocardial function and treatment outcomes for CHD. And when he's not working, and of course before quarantine, Shelby loved visiting US parks and museums. It's been a crazy year for all of us. And we thought it would be perfectly appropriate with this two-part webinar focused on the origins and the development of the treatment of tetralogy, starting at Johns Hopkins, where Shelby is the chief. And Shelby, take it away, please. Are you speaking, Shelby? I can't hear you.
I am. Thank you, Gil, first of all, for the introduction. Let me share my screen. I think we are good now, right, Grace? Great.
Perfect.
Great. Thanks, Gil, for the introduction. Hello to everyone around the world. At the outset, I'd like to express my sincere appreciation to the Congenital Heart Academy leadership, Grace, Sasha, and Gil, for organizing this special webinar. In 1944, a profoundly cyanotic child born with tetralogy of Fallot entered an operating room, and for the first time in history, emerged from that operating room alive and pink. The magnitude of this achievement might be hard to fully comprehend today. A surgeon, a cardiologist, and a lab technician had joined forces to produce the first successful palliation for cyanotic congenital heart disease. This operation was a triumph of courage, determination, physiologic insight, and scientific innovation over a seemingly insurmountable clinical problem. Certainly, it's a model for bench-to-bedside clinical investigation, fundamental for medical progress. But it's also a story of how barriers of discrimination are ultimately overcome within academic medicine. Although it took far too long, Vivian Thomas, pictured here with Helen Taussig and Steve Muller, president of Johns Hopkins, was finally recognized for his foundational contributions with a doctorate degree in 1976. Palliation is great when there are no better choices available. But the 1944 pioneers of congenital heart surgery would have wanted us to go much further. We recognize that a systemic to pulmonary artery shunt leaves the patient with at least some ongoing arterial desaturation and continued right ventricular pressure overload. It burdens the left heart by asking it to supply pulmonary arterial blood flow. Later adverse consequences seem inevitable for our shunted patients with tetralogy. To make further progress in the management of tetralogy, we needed many new ideas. We were going to need to understand cardiovascular pathophysiology much better. A better understanding of the genetic component of this condition was going to be helpful. We really needed advances in surgical technique and cardiopulmonary bypass to allow intracardiac procedures. More accurate and powerful diagnostic imaging technologies were required. We needed medical management strategies to limit the late effects of cardiovascular load stresses and ways to organize delivery of lifelong care to adult survivors. All this work is still ongoing, and to push forward, it clearly takes a village. This webinar has brought together a talented and diverse group of specialists to address the current state of all the moving parts that are essential for the best care for tetralogy of Fallot. I'm especially glad to see some of my long-term personal friends, Tom Call, Z Hijazi, Jeff Jacobs, Charlie Barul, and my dear Hopkins buddy, Darren Klugman, in this excellent panel of speakers. We clearly need to work out a few things if we are going to improve the prospects for these patients. We must characterize the relationship between pulmonary regurgitation, ventricular size, and myocardial function. While it's feasible to replace the pulmonary valve, we still need to know the optimal timing for this and identify those patients who derive benefit from a new valve and distinguish them from those who do not. It would be wonderful to have sensitive and specific biomarkers which could alert us to the risk of adverse events such as arrhythmia, declining ventricular function, changes in exercise capacity and quality of life, and of course, mortality. It's November 30, 2020, but some things never change. The same 1944 model of scientific investigation must remain vigorous in the present day in order to respond to ongoing challenges. Today's investigators will be hampered by small numbers of clinical research subjects with tetralogy. They're simpler not the numbers we get for study of acquired ischemic heart disease in adults, for example. Furthermore, broad heterogeneity in patient anatomy, treatment approaches, and surgical era complicates the use of traditional research methods. Indeed, our current research continues to transform data into insights every day. We may, however, be approaching a point of diminishing return from this classic approach. We now begin to ask, how much will patient outcomes improve from the insights into disease processes we currently get from our clinical research? Shouldn't our goal really be to take all this information and use it to implement appropriate changes in management from which improved outcomes will result? The next evolution will require, in my mind, a fundamentally new approach. Such an approach will involve three paradigm shifts. First, we will need to focus on predicting the lifelong clinical trajectory for patients instead of relying solely on short-term horizons. Second, we need to embrace the complexity of biological systems instead of attempting to deconstruct them and study the individual components in isolation. Complex systems don't necessarily behave like the sum of their parts, and as such, the focus should switch to whole system behavior. Finally, we may benefit from moving beyond the traditional approach of reducing clinical problems to simply a compilation of traditional risk factors. We should start tapping unreduced data sources using newer and more powerful analytic methods. To illustrate this concept, consider a life trajectory project we recently launched in our institution, led by Cedric Manu and I and the Cardiovascular Analytic Intelligence Initiative. We begin with multimodal clinical data input, including imaging, lab diagnostics, and genomics obtained through consortium hospitals. Next, patients consent to share and report outcomes, which are collected through mobile applications. After that, data is processed and integrated using artificial intelligence-based feature extraction algorithms. This allows for application of advanced analytics and machine learning for predictions and trajectory mapping for the patient. The predictive models that are produced can then be tested through clinical trials in associated hospitals. All of this may seem speculative from our perspective in late 2020, but here are some examples of deep learning and computational risk predictive modeling projects currently ongoing at our institution, led by my colleagues, Drs. Ashish Doshi, Natalia Trinova, and Cedric Manu. Today's teams are different from the teams of the past. We all are far more diverse, dispersed, digital, and dynamic, just like this global webinar. However, we still can form a great team. The foundation for it is to have a direction that energizes and engages people, a structure that includes members with a balance of skills, and all this in a supportive environment. So much has changed in our understanding and management of tetralogy of Fallot. But science is still the name, and collaboration is still the game. Scientific collaboration is even more vital today than it was 75 years ago. Only highly integrated and interactive research teams are going to be successful in developing and sustaining efforts. The critical pieces for success are trust, developing a shared vision, and building the team, along with self-awareness and good communication among the team members. In this way, we can have the optimism that the achievements of the past are only a small step towards a very bright future for our patients with Tetralogy Fellow. Thank you for your attention. I'll now turn it over to Gil to introduce our keynote speaker.
Shelby, thanks so much for that rapid review and reminding us that this is, to quote my good friend Darren Klugman, the ultimate team sport, what we do. And I'm really pleased to introduce our keynote speaker for this first part of the webinar, our dear friend, Dr. Tom Carl. Tom is a professor of surgery in the Queensland Pediatric Cardiac Research Center, which is at the University of Queensland. And he's a retired professor of surgery from Johns Hopkins and from the University of California, San Francisco. He's the associate editor of the European Journal of Cardiothoracic Surgery and Cardiology in the Young. He is very active in humanitarian pediatric cardiac surgery and has been involved in teaching and operating missions in 21 different countries. Tom is an avid builder and rider of custom road bikes and a lifelong downhill skier of the Sierra Nevada range. He is, along with myself, co-founder of the Baby Blue Sound Collective, which he describes as an eclectic orchestra performing original compositions in multiple genres. And I'm really, really pleased to introduce Tom to give us our keynote lecture, Tetralogy of Flow, What We Have Learned During 75 Years of Surgery and a Global Perspective. Dr. Carl.
Thank you very much, Gil. Can you hear me?
Yes, perfectly.
Okay. Well, hello, everybody. And it's a great honor to be invited to deliver the keynote lecture in this symposium. I'd like to speak about Tetralogy of Fallot and what we actually know after 75 years of surgery. Tetralogy of Fallot is, of course, our prototypical lesion, the first cyanotic lesion to be well characterized. Our first palliative and definitive cardiac operations were done for Tetralogy of Fallot. And very importantly, Tetralogy has given us the first cohort of long-term survivors of repaired cyanotic congenital heart disease. And I think we can all agree that the work of the past 7 decades has resulted in an effective alteration of the natural history of the disease. Even though late problems are frequent and at times severe, the perceived health status of most tetralogy patients decades after their operations is usually perceived as normal. If we look in PubMed, in the English language
Tom, do you want to
alone,
put your, Tom, I think you need to put your slides up if you're showing slides.
I am. I thought they were up. I'm so sorry.
No worries.
I have share screen on. Can you see the slides now?
No, we can't.
That's
when
a
you
problem.
when you go to share screen, you should be able to click on your desktop or PowerPoint.
Yeah. How about now?
Here we go. Yep, now just put it into presentation mode and you're all
Yes,
good.
yes, doing it. Okay.
Thank you, Tom.
Yep. I'll just run through these slides. That was the picture of Fallot that I meant to show you. And I was saying that there are nearly 11,000 articles in the English language in PubMed today. And thousands upon thousands of tetralogy operations have been performed worldwide over the past 75 years. And one would really wonder if there's anything more to say about it. On the other hand, despite the long history, the best surgical technique remains a continued subject of debate. And I think it's fair to say that what we learn about the late evolution of tetralogy constantly redefines our primary strategy. Interestingly, we humans are not alone with this disease. It occurs in dogs, cats, horses, ferrets, cattle, lambs, and so on and so forth. And this is a picture of a common ferret with a low hemoglobin saturation. And I think we can also agree that there is a typical cour en sabot pattern on the plain X-ray. So that's a little interesting fact that I came upon when I was preparing for this lecture. Another thing that is possibly new in our understanding of tetralogy is the challenge to the dogma of sporadic mutation as the main cause of tetralogy of Fallot. We now have some genes recently implicated in non-syndromic tetralogy, which makes up about 85% of cases. But I'd like to focus a bit more on the surgical side of this disease. The goals remain the same today as they did in the time of Blalock and Lillehei. We'd like an operation that's free of mortality and major morbidity, that delivers a functional pulmonary valve, a normal right ventricular pressure, preserved left and right ventricular function, both systolic and diastolic, preserved conduction tissue, and a universal suitability with a good long-term outcome. Let's go back to 1944. The world was a much different place. And like now, there were many astounding events that took place during the span of that year. And I've shown some of them on this slide, and I'm sure all of you are familiar with these events. Well, this is also the year that Blalock and friends developed the iconic Blalock-Taussig Thomas shunt. And as Shelby mentioned, this was a gender and racially integrated interdisciplinary team employing a complex novel operation to create a new lesion, which they hoped would palliate a desperately unwell child. And I think as clinicians, we can agree that the physiology after the Blalock-Taussig Thomas shunt can be difficult to manage even today, especially in certain types of patients. That makes this accomplishment even more remarkable. And this picture will probably appear in the slides of every speaker on the program, but that's okay. You can see Alfred Blalock operating with Vivian Thomas standing behind him giving advice. And William Longmire was the first assistant, eventually to become a big name in surgery himself. And this operation was made possible in part by the development of some new surgical instruments. This one is for occlusion of the subclavian artery. And it was developed by Vivian Thomas himself. So let's take a look at some of the players on this team. Alfred Blalock received his MD from Johns Hopkins in 1922. That became the first resident in surgery at Vanderbilt University. His research centered on shock and fluid resuscitation and transfusion, and this work resulted in saving countless lives in battlefield hospitals during World War II. Blalock eventually returned to Hopkins as surgeon-in-chief and director of the Department of Surgery, and he held this position till his retirement in 1964. And thankfully for our specialty, Blalock was able to convince the Johns Hopkins administration to bring his lab technician, Vivian Thomas, with him. The racist policies of that era disallowed African Americans on the professional staff, not just at Johns Hopkins, but at many American universities. Well, Vivian Thomas was an amazing character in his own right. He had abandoned his medical study plans after the stock market crash of 1929 in the United States, and he did spend most of his career as Blalock's lab assistant. As such, he was able to contribute significantly to Blalock's early research on shock and hypertension as both a technical and intellectual collaborator, again, almost unheard of in the era. And of course, Thomas was the silent partner in the development of the Blalock-Taussig Thomas shunt, and he has now been appropriately recognized and honored not only by Johns Hopkins, but by everyone else in our specialty. And has the time come to rename the Blalock-Taussig shunt? Well, of course it has. And I think that this operation is now referred to as the BTT shunt in almost every venue. In the lower right-hand frame is a photograph of the actual first survivor of the Blalock-Taussig Thomas shunt. This is Anna, who was a lab animal. And after she survived the operation, she was freed from her duties and further research and kept as the pet of Vivian Thomas in the lab. And she was occasionally brought out to visit survivors of the Blalock-Taussig Thomas shunt. You've already seen some frames from the film advertised on the left. There are actually 2 film accounts of the relationship between Blalock, Vivian Thomas, and Helen Taussig, and they're both very good, highly entertaining, and to the best of my knowledge, quite factual as well. This leaves Helen Brooke Taussig, who is, of course, the mother of pediatric cardiology, another amazing character from Johns Hopkins. She graduated in 1927, remained there for her pediatric career, and she very early on recognized the pathophysiology of tetralogy of Fallot and the important role of ductal closure. Supposedly in 1943, she posed the question to Blalock, if you could put the carotid artery into the descending aorta for a coarctation repair, couldn't you put the subclavian artery into the pulmonary artery? And of course, the rest literally is history. And Tausig's landmark Congenital Malformations of the Heart was published in 1947. The BTT shunt provided proof of concept, but it had many important consequences. It was known now for the first time that hemoglobin saturation and polycythemia could actually be improved just by increasing pulmonary blood flow. It was learned that the subclavian artery could be sacrificed without extremity loss or brain damage, which actually was not known prior to this procedure. There was proof that hemostasis was possible in complex vascular procedures, even in cyanotic patients, that safe anesthesia was a possibility in the same type of patients, that the history, physical, chest x-ray, and fluoroscopic exam could be effective diagnostic tools. It also marked the ascent of pediatric cardiology as a specialty and the inclusion of translational research as an important concept in that specialty. And as Shelby also mentioned, this was possibly the beginning of the resolution of some of the injustices that permeated academic medicine based on both gender and race. There are some other players in the BTT story whose names may not be as familiar. Olive Louise Berger became the chief nurse anesthetist at Johns Hopkins in 1931. And during her 38 years there, she witnessed the transition from nurse technicians as anesthesiologists to physicians and the creation of another new specialty. Berger and her fellow nurses continued to perform much of the day-to-day work of hospital anesthesia, and the BTT shunt operation really illustrates this continuity amidst change. And finally, Richard Bing, who set up the Hopkins Laboratory for the physiologic and diagnostic study of congenital heart disease. Incredibly, by 1947, over 100 tetralogy patients had been catheterized. This would be an accomplishment even today. Bing, Blalock, and Thousig, as most of you know, identified and published on at least 20 different types of congenital heart defects, including the Taussig-Bing anomaly. What you may not know is that Richard Bing was also a true Renaissance man, an author of 500 peer-reviewed scientific articles, composer of more than 300 pieces of classical music, and author of 5 books of fiction. Well, let's jump ahead 10 years and look at the world as it was in 1954. Again, an astounding set of accomplishments and events occurred that year in various fields of endeavor. And one of the greatest of these achievements involved the first open heart surgical procedures. There were several players in this story, but the one who is really best known is C. Walton Lillehei, working at the time at the University of Minnesota. And he performed our first successful open heart procedures using cross circulation, generally, but not always, between parent and child. These operations were performed in the face of strong peer opposition, including pushback from his chief of medicine. But Lillehei persisted, and again, the rest is history. He stopped operating at the age of 55 years for health-related reasons. And interestingly, this is the current median age for pediatric cardiac surgeons working in the United States. Lillehei was a pioneer in so many areas of pediatric cardiac surgery. We have to ask why there is no eponymous operation in the Lillehei legacy. And finally, at least 820 cardiothoracic surgeons from 36 countries at last count can trace their lineage to C. Walton Lillehei. And of course, I include myself in that group. This is a photograph taken during the first operation with cross circulation. And you can see that there's another all-star team here, consisting not just of Lillehei, but Richard Varco, Morley Cohen, Herbert Warden, Vincent Gott, Norman Shumway, and last but not least, the patient's father, who served as the donor pump for this operation. The child was 13 months old, had an unrestricted ventricular septal defect, may not have been the best surgical candidate, but was going nowhere clinically. Operation was done without any aortic clamping, 19 minutes of cross circulation. The pump sucker had not yet been developed, so there was no salvage of blood possible during this operation. The patient survived for 10 days, succumbing to pneumonia, but Lillehei, in very short order, achieved much better success with subsequent patients. Between 1954 and 1955, when this technique was abandoned in favor of an assembled mechanical pump and oxygenator, Lillehei operated on 45 children using cross circulation. This cohort included the first repairs for ventricular septal defect, Tetralogy of Fallot, and atrioventricular septal defect. And I can tell you from looking through the archives that these were not always straightforward cases. 62% of the patients were discharged alive from the hospital, and 49% were alive and well 30 years later. And the actuarial curve is shown on the left. Well, let's talk about surgery for Tetralogy of Fallot today. The technique employed by Lillehei involved a transventricular approach to both the right ventricular outflow tract obstruction and closure of the VSD with or without a patch. This transventricular repair has been nominated as the cause of many of the late problems that we see in Tetralogy of Fallot survivors. Yet somehow it never seems to go out of style. If you look at the STS and EXA databases, you can see that even in recent times, the majority of teams prefer a transventricular approach for repair of Tetralogy of Fallot. And one would have to wonder if this is the true Lillehei legacy. As a forward-thinking surgeon, it's hard for us to accept that Lillehei would not have refined this operation in such a way that the function of the pulmonary valve and the right ventricular myocardium could be better preserved. This is an extremely important paper that I don't think has had its due recognition, written by Alessandra Frigiola, published from Great Ormond Street in 2013, looking at the phenotypic characteristics of late survivors of Tetralogy of Fallot repair who are free from pulmonary valve replacement. And using a number of imaging and other physiologic techniques, the team determined that mild right ventricular outflow tract obstruction is a good thing, and as has been suspected clinically for decades, could be protective in some way from the long-term effects of pulmonary insufficiency. And I think this type of information is well worth our notice, since this is probably one of the main problems seen today in adult congenital heart disease clinics, and is certainly the most common reoperation in that specialty. The other point that is a subject of continuous debate is the best timing for elective surgery in tetralogy of Fallot. The fact is that most tetralogy patients do not require neonatal surgical treatment based on cyanosis alone. Ductal dependency is one cause, but this is probably best treated with stents today in the majority of cases. So the important surgical argument, therefore, is not primary repair versus a palliative shunt, but rather non-neonatal versus neonatal elective primary repair. And we have gone back and forth on this for decades, and I've worked in institutions that favored neonatal repair for all patients. I've worked in other institutions that have favored a more conservative approach, and I'll talk about that in a moment. So there was a very good paper that was published from one of the sponsoring institutions for this symposium, dealing with a mathematical model for the best timing of elective infant tetralogy repair. And it was calculated based on the probability of reintervention at 2.3 years, that 55 days of age was the optimal time. It's interesting because I think that this is a time frame that's extremely well accepted and practiced by most large centers in the United States today. On the other hand, when we talk about tetralogy of Fallot repair in disadvantaged or developing countries, the equation will change considerably, mostly because we don't even see these patients, and the ones who are ductal dependent probably don't survive to have later treatment. Well, for some decades, we've favored the transatrial transpulmonary repair of tetralogy of Fallot performed in non-neonates. With this strategy, the right ventricular incision is limited to about 20 millimeters, and a transannular patch is applied as needed based on a Z-score less than 0 after complete mobilization of the pulmonary valve leaflets. This is done in an anatomic fashion, and if a transannular patch is needed, we almost universally employ pulmonary valve leaflet augmentation by the Sung technique to preserve pulmonary valve function. Why do we think a transannular transpulmonary approach is good? Well, certainly the functional contribution of the infundibulum to the right ventricular stroke volume is minor compared to that of the body of the right ventricle. And it's been known for years that this approach results in less right ventricular dilation and better preservation of contractility at late follow-up. And looking at some of our patients from the Royal Children's Hospital in Melbourne, there was an 87% freedom from pulmonary valve replacement and clinically significant right ventricular dilation at 25 years follow-up for patients operated according to the strategy that I just outlined. For the past 2 decades, we have added pulmonary valve leaflet enlargement in cases that do need a transannular patch to achieve an adequate right ventricular outflow tract. This whole operation is possible at any age. It's easier and more reliable in non-neonates. It can be done at full flow cardiopulmonary bypass with little or no hypothermia, and certainly there shouldn't be a need for any circulatory arrest. Importantly, this technique allows us to close all atrial communications to prevent postoperative cyanosis, which can be somewhat unpredictable. And the goal of the operation, which we can usually realize, is to eliminate early pulmonary insufficiency and right ventricular outflow tract obstruction following the operation. Now, I wish I could say that these improvements were sustained in the long term, but that unfortunately is not the case. And I'll say a word about that in a moment. This is what the transtricuspid resection of the parietal extension of the infundibular septum looks like. And on the right-hand side, transtricuspid valve closure of the malalignment VSD, which is virtually always possible in tetralogy of Fallot. In fact, there are much more difficult VSDs that we routinely close through the tricuspid valve. And this aperture actually gives you a much bigger operative field for VSD exposure than would a small right ventriculotomy. So if the Z-score following mobilization of the leaflets is inadequate, then we divide the anterior pulmonary leaflet through its midpoint. We might vary the location of this incision based on particular anatomic characteristics. And then a two-patch repair is employed. The first patch is sutured to the cut pulmonary valve leaflet edges and the endocardium of the right ventricular outflow tract, which has the effect of augmenting the anterior leaflet. And we calibrate the orifice to a Z-score of +2. This effectively moves the annulus inferiorly, and some of the hinge mechanism function is probably preserved. The second patch is then sutured to the pulmonary artery incision and to the right ventricular outflow tract epicardial edges. And in doing this, we create a bi- or tri-leaflet pulmonary valve with an anterior sinus of Valsalva. This is not a monocusp repair, as has been proposed by many teams in the past, but an enlargement and preservation of the existing pulmonary valve leaflets, which we expect will coapt following repair. And importantly, the entire transannular patch with this technique is effectively moved to a supraventricular position. Our initial experience was reported when I was working in San Francisco, 43 patients, and we were able to demonstrate an improvement in the immediate postoperative course in the intensive care unit compared to contemporary and historical controls. And we noted that there was a freedom from moderate or worse pulmonary insufficiency of about 75% at 5-year follow-up, with very rare occurrence of any residual right ventricular outflow tract obstruction. And in these echo frames, you can actually see the coaptation of the augmented anterior leaflet and the native posterior leaflet. More recently, and this paper is currently in press in JTCVS, we've reported the outcome for 131 cases operated in Brisbane and Liverpool between 2007 and 2019. The median follow-up was about 74 months. And at 5 years, the freedom from severe pulmonary insufficiency was 78%, similar to what was reported in the previous study. And patients who had their leaflet augmentation done with 0.1 millimeter PTFE as opposed to glutaraldehyde treated autologous pericardium were at lower risk for progression of pulmonary regurgitation. This is what freedom from reintervention for pulmonary stenosis looks like. Also, at least as good as repairs that we have used in the past. So, in summary, the Sung transannular transpulmonary technique is a good choice for infant tetralogy repair when the pulmonary valve leaflets cannot be spared due to the restrictive nature of the right ventricular outflow tract. This operation does provide reliable early control of pulmonary insufficiency and right ventricular outflow tract obstruction, and as such is probably a useful tool for improving the early postoperative course. The long-term outcome may be better than for other transannular patch strategies, but it remains imperfect, as I said earlier. It is certainly competitive with other valve sparing strategies. The technique is straightforward and suitable for most cases, and it's quite reproducible and easy to learn and teach. Well, there would be a lot to say about repaired tetralogy of Fallot as an entity, and it really is like a new disease with its own prevalence, physiology, and unnatural history. And I think one could spend an hour talking about this problem. I won't do that, but I would just like to introduce you to a good friend of mine, Mike Edinburgh, who is reporting to us today, a former BTT shunt patient back for his 75-year follow-up appointment. And I'd like to welcome you, Mike. Mike had his operation for tetralogy of Fallot on the 2nd of October, 1945, age 2 years and 7 months. And this operation was performed by Alfred Blalock himself. He was logged into the Hopkins Clinic by his cardiologist, Helen Taussig, as blue baby number 44. And that's a picture of Mike on the left a few weeks after surgery and on the right as he looks today. My association with Mike is based on my work with Gift of Life International in the Philippines, where Mike has lived for some years. Here are some letters regarding Mike's follow-up, one signed by Helen Taussig, one signed by Alfred Blalock. These are important historical documents which now reside in the Johns Hopkins archives. And here's Mike with some members of the Gift of Life International team and a patient and his father at the Vicente Soto Hospital in Cebu City. So I'm going to let Mike talk for himself and tell you a bit about his life. I have a few questions that I'll pose. And then Gil, correct me if I'm wrong, but I believe that we'll be open to questions for Mike, who also may have a few questions for all of us. So thank you for your attention during my portion of the talk. And Gil, can you bring Mike online, please?
Yeah, I think if you stop sharing your slides, then we'll have the, and if the people in the audience go to the upper right-hand corner of your Zoom screen, and where it says view with a bunch of little boxes, if you click speaker, you will get Mike when he is speaking and Tom when he is speaking. And Tom, thank you very much for that. And Mike, I have one question before you start. I know you're a jazz aficionado. Who is your favorite keyboard player?
Favorite what?
Your favorite keyboard player?
Oh, well, Thelonious Monk, for one.
Good answer.
Obviously, excellent neuroprotection during both operations. And I'll turn this back over to Tom and Mike to share their experience with us. And Mike, thank you for joining from the Philippines.
My honor. Thank you.
All right, Mike. Yes, it's a great honor to have you with us. And I must say you're looking quite well, as you always seem to. I'd like to ask you a few questions, and then you can make any sorts of comments that you want. You may have some questions for all of us. What do you remember about your childhood in terms of any disability or physical limitations after your Blalock Taussig Thomas shunt operation performed at Johns Hopkins?
I remember having to go up a hill to like second and third grade, and it was a pretty significant incline, but my sister was having no trouble with it. But I would have to stop once or twice along the way and catch my breath. And then I also recall my father bought a powered lawnmower, and that was my job to mow the lawn, which was fine. Well, it wasn't a push, it was all gasoline powered, you know. But by the time I finished the yard, I had a raw throat from breathing so hard. So I was constantly winded when in situations like that. Another painful memory, which is why I'm here, is cold weather. I really suffered in the cold weather. So, and Iowa is noted for pretty severe winters, and so is the Northeast, of course. So when I retired and chance to move here, I jumped at it, and been walking around in shorts and sandals ever since, for the most part.
All right. So, Mike, you lived for a long time, some 17 or 18 years, just on the shunt palliation. In fact, when you had your shunt operation, the complete repair hadn't really been accomplished. That was almost 10 years after you were treated. So you didn't wind up having a tetralogy repair until you were about 20 or 21 years of age. Is that correct?
Yes, it was my 21st birthday present. I spent my 21st birthday in a hospital.
Tell us a little bit about your memories of that ordeal.
I had been involved in an automobile accident where I got a bad cut inside my mouth from my teeth due to head-on collision, and I got SBE. So I was out of school the whole third quarter of my senior year in high school, and was take penicillin, be okay. A few days later, fever's back, off and on, off and on. So finally, one night, it just really had my parents fearful that I wasn't going to make it. So they called Dr. Ruth Whittemore at Yale, who had worked with Helen Taussig for many years. And he said, bring him now. I just had my fever broke. So they brought me in the morning. And I was on 12 million units of penicillin, for about a couple of weeks. And that killed the bacteria. But then that accident really saved my life, because I didn't realize how sick I was until they had a chance to evaluate me and find out that the tetralogy the BTT shunt wasn't capable of handling somebody in their 20s.
And how long after your treatment for endocarditis did you wait for your complete repair?
It was about 4 or 5 months, as I recall.
4 or 5 months. And that was performed at Yale University by Dr. Horace Stansel, another big name in cardiac surgery.
Yes.
How did you feel after the operation? Did you notice a difference?
Oh, night and day. Talk about being reborn. I was reborn.
How long did it take you to recover from that operation, till you felt 100% again?
I would like to say, when I came home after, I think I was there 3 weeks of recovery. And then when I came home, I went up the stairs. I wasn't supposed to go upstairs, but I knew my limitations. And I had no problem. And I mean, pretty much right from the get-go, as soon as I got home, I never looked back, and I was fine. So I don't remember any issues after that. I remember before that, all my friends were always having to wait for me to catch up to them because I was huffing and puffing. And after the operation, the reverse was the case. I was waiting for them. So
okay,
I was much energized.
Now, this is a question that you and I have probably discussed in the past in Cebu, but at what point did it occur to you that your story might be extraordinary and that there weren't a lot of people like you walking around with relatively early in the piece repair of a complex congenital heart problem? Was this on your radar screen at the time?
I never really thought too much about it, but I think the thing that caught my attention was something the Lord made. When that movie came out, I thought, oh, I know all about that. And
I guess you did.
That's when I became a little aware that maybe there's some significance there.
Do you have any significant memories of your medical team, of Helen Taussig or Alfred Blalock?
Not, and I didn't ask my parents, but I did follow up with Helen Taussig, and Helen Taussig used to thump my chest with her fingers to get an idea of the size of my heart. This is a woman who was hard of hearing. I don't know if I'm sure most of you.
Yeah, we know about that. Yes, amazing story.
My mother, I remember, treated her like royalty whenever I was brought there to be evaluated. She was extraordinary lady.
So Helen Taussig was the keynote speaker at the Second World Congress of Pediatric Cardiology, which was held in New York City in the 80s. And in her later years, she became very interested in bird hearts. And her lecture was about avian heart morphology and the similarity between bird hearts and the hearts of children with congenital heart disease. I don't know if I ever mentioned that to you, but like the others involved, she had a lot of far-reaching interests, even outside of pediatric cardiology per se. So, Mike, you have had a very successful life, and from what I know of you, it seems like a very happy life as well. And I think that you've demonstrated that you've survived all of this with your cognitive function well intact. You started your own computer business, which was successful, and you're, active today with the specialty. How do you feel about that? I mean, would you say that your health and stamina and so on is the same, better or worse than other people in your era at this age?
I mean, in my head, I'm still in my 20s, I still weigh the same as I did. I still walk the same as I did. Everything is, except my forehead has gotten a lot higher, a lot larger, That's the only difference I can put my head around. So I'm doing great, I did have a back injury, so I had that operated on, and I did lose a kidney in 2001. But other than that, putting me to sleep for a surgery is nothing, doesn't faze me in the least.
Yeah, I can see from your story that you're not a stranger to adversity, but somehow you always prevail. People like you are the reason that are one of the big reasons that we all do what we do. And I was just wondering if there's anything specific that you'd like to say to the pediatric cardiac community. Yeah, even if it's a complaint, Mike, it's okay.
No, I just am really in such admiration for what you all do, because I can't understand what it could be other than just love for helping children with the problem. I mean, that's the only thing I can get my head around. Why else would you go into a field like that? That has certainly its ups and downs, more ups I know than downs, but there are times when it's not great, and those
Yeah,
have to set those with the others. But the rewards are hard to.
yeah, well said, and I think most of us would agree with that. I think this would be a good point to open it up to questions, if that's okay with you, Gil.
Yeah, it is, Tom. The way the webinars are set up is that we don't have the ability to have an audience member approach a microphone.
Right.
So what I would encourage people to do on the bottom of your Zoom screen, not the chat function. It's important you don't use the chat function. Use the Q&A box, and you can ask questions to Mike. And Mike, I suspect there may be one or two. You may be busy for the rest of the webinar, but you'll have a chance when you respond. Everybody can see your responses. And it's just been truly amazing to have you as part of this, to hear your story. Hope and triumph seem too small of words for me to put into my, I just can't put it into words, as you can tell. I mean, it's just been absolutely amazing to hear you. I did want you to know, Mike, that just as a token of our appreciation, we have made you a Congenital Heart Academy shirt.
Wow.
And it's got the number 44 on the back.
Really? No kidding.
Yeah, and you'll be receiving that in the mail. We'll be getting your address, and it seems like such a small token of our appreciation, but it's just been terrific to have you. You're now officially a faculty member and a well-loved member of the Congenital Heart Academy.
I can't wait to wear that to a Rotary meeting, because the Rotary is life.
That's great. And we're going to have to talk music at some point, but I'm going to close this portion of the sentence. Is there anything else you'd like to tell everyone out here? Or Tom, do you have any closing remarks?
Maybe, Mike, you would like to just say a word or two about your involvement with Gift of Life and the humanitarian pediatric cardiac surgery program.
Good idea. I joined a Rotary Club when I moved here, because I really liked helping people. And then I moved to Cebu and joined another club, which I had no idea was a Gift of Life club. And once I found out, then I couldn't believe the fit. So we've operated on thanks to people like Tom and Rodrigo, over 400 people have been saved in Cebu because of their kindness and their dedication. So we have what they call a VTT, which is a vocational training team. And the people like Tom come in and teach the local people even biomedical engineers come in and teach the engineers here how to do what they have to do. So anesthesiologists and perfusionists and everybody, the whole team, 20 plus people come here 3 or 4, before COVID, 3 or 4 times a year just to do that. So that's a real act of love. One other thing I want to mention too, it's not that significant, but one time I had changed schools from a very small school to a school with 3,000 students. And I was walking down the hall one time, and I'm 126 pounds. I've always been 126 pounds since I can remember, since high school. And some jock, some bully said to me, "Hey, Skinny, your ribs are showing." So I kept walking for a few steps, and I thought, I'm not gonna let him get away with that. So I went back to him and I said, "See these fingers? See that blue?" "Yeah." "Well, that's a heart condition. Just thank God you don't have it." I turned around and walked away. His friends were really laughing it up until I said that, and then dead silence. So hopefully he's not a bully anymore, you know. Hopefully he learned a lesson from that. So this has its pluses.